So good afternoon, everybody. I'm Agnes Attakai. I'm with the University of Arizona's Health Sciences. I'm with the College of Medicine and College of Public Health. I'm affiliated with the Center for Rural Health, which is located within the College of Public Health. And I'm Diné Navajo. I grew up in a small community called Tisto, Arizona, and my family migrated and moved over to Winslow, Arizona, which is a border town in northern Arizona, and also in Glendale, California. My parents were part of the urban relocation program where they were encouraging young Native people to move to the urban areas, to be assimilated, to get job training and education. And that's where I grew up. So I was more of a migratory person going back and forth between various environments. And that's how I grew up. I have a bachelor's in political science and a master's in public administration and several other trainings, but a lot of experience working out in the community. And so one of the questions I get a lot is what is public health equity? And I wanted to talk a little bit about what public health equity is. And so I will actually start off with a presentation. I will turn off my video for most of the time. But if you have any questions, please raise your hand for any questions, or if you feel comfortable and want to put your questions in the chat, that would be awesome as well. So I want that you be able to have a thorough understanding of what health equity is in public health. So I will start sharing my screen, and then we will go from there. Okay. And let me just turn off my video. Okay. So the presentation I'm going to talk about today is focusing on health equity. And this is a modified version of a presentation that's provided by the CDC Museum. And it's part of their Public Health Academy, and it can be accessed. And I did put the link in the chat room, so you have access to this information. It's public information. You can use it to modify for any presentation you want it to do on health equity. So we're looking at what is health. So we talk about health as a state of complete physical, mental, and social well-being, and not merely absence of disease or infirmity, meaning that you don't have to focus so much on someone's illness and someone having a disease, but it's really being healthy in being physically, mentally, socially, and psychologically healthy. So that is health, and health encompasses everything. So health really begins where we live, work, worship, and play, according to the Robert Johnson Foundation. So let's think of a couple of, we'll do a little interactive exercise here. So what do you think would be the built environment? So let's look at what the built environment is. Oops, it's not working. Okay, let's focus on disparity. Okay, so it doesn't work as how I thought it'd be, but disparity is really preventable difference in the burden of disease, injury, violence, or opportunities to achieve optimal health. Another term that's also common when we talk about health equity is health inequity, when factors like education, income, gender, environment, and ethnicity cause unfair differences in health outcomes. So let's look at the built environment, which is the human-made environment where people live, work, and play each day. And health equity is when everyone has the opportunity to be as healthy as possible. And of course, public health is the science of protecting and improving the health of people and their communities. And the social determinants of health are the conditions in which people live, work, learn, and play, and worship. And these contribute to health inequalities. Oops. So understanding health equity. So health equity is achieved when no one is disadvantaged from achieving their full health potential because of social position or other socially determined circumstances. So health inequalities are reflected in differences of length of life, quality of life, rates of disease, disability, and death, severity of disease, and access to treatment. So we've seen this recently with the health impact of COVID-19 on exposing long-standing inequities that have systematically undermined the physical, social, economic, and emotional health of historically underserved people. And of course, historically underserved people also bore a disproportionate burden of COVID-19. So, for example, in my family, I am Navajo, and Navajo people disproportionately were impacted by COVID-19. Every single member of the Navajo Nation has experienced some form of illness through family members and death. And unfortunately, in my family, during the last year of COVID, before the vaccines were available for folks, I lost 13 members of my family. Everything from my uncles and aunts to cousins. And so we ran the gamut from folks who were in their 70s, cancer survivors, and those who are on dialysis, to young people who had asthma and other autoimmune disease. And so really, we looked at what were some of the reasons why they were high proportionate deaths. And it was because they had an underlying chronic health condition, but also because they lived in rural communities where by the time they reached a hospital, they had to be flown out from the Navajo reservation to urban areas like Tucson and Phoenix and Albuquerque. And by that time, the disease had progressed to where they had to go on lung systems in order to help them breathe. So achieving health equity requires valuing everyone equally with focused and ongoing efforts to address avoidable inequities, historical and contemporary injustices, and the elimination of disparities in health and healthcare. So I want you to think about what are a few reasons why a person might not go to the doctor. How often do you go outside? Do you think this affects your health? And how far do you have to travel from your home to find a store that sells affordable fresh vegetables, fruit, and meat? And could you get there on foot or by public transportation if you needed to? And just gives you a couple of minutes to think about this. Because when we talk about public health, we're talking about the health of people. So everywhere we live, work, and play. So it's not so much about disease, but the reasons why they're unable to go to a doctor. And maybe there's challenges for them to be physically active because they're unable to go outside. And this really impacts their health. I live in a really rural community here in Pima County. And I used to walk a lot before there was more development in this area, and it was a little more safer. Now I'm unfortunately unable to walk because we have a lot of folks who have very aggressive dogs for security reasons. And many times those dogs are roaming around. So it's unsafe for me to really walk here in my neighborhood. So I actually have to go in town to a park to walk. And I live about six miles away from a grocery store here in Pima County. And living on the Navajo reservation, when I was younger, there were only, at the time, 10 grocery stores locally. Now there's 13. So having 13 grocery stores in the size of the state of West Virginia. So how does that impact a person's ability to find fresh vegetables, meat, and fruit at a store? And if there's no refrigeration due to a lack of electricity, how can you store those? And so you end up buying more canned items. So really think about, where people live, work, and play when we talk about public health. You interact with folks who are who need our services. You've probably seen this diagram before. So when we talk about health equity and health equality, they mean different things. They're not the same thing. In the graphic, the equality example shows 4 people who are all given the same bicycle. The child can't reach the pedals, the man is hunched over with his knees on his chest, and the person who uses a wheelchair cannot ride at all. only the woman can comfortably use the bicycle. So equal distribution of resources has not produced equal outcomes. However, in the equity example, all riders were provided bikes that match their sizes and abilities. When provided with specialized bikes that were tailored to their needs, everyone was able to achieve the same outcome, meaning getting to where they need to go. So when we work in public health, we have to meet people where they are and really address the circumstances that bring them to us and help them to achieve as healthy as they can be. We also talk about social determinants of health and health equity. So social determinants of health are factors that can include social, economic, and environmental conditions in a person's life that have an impact on a person's health. These conditions can cause differences in people's health for different groups of people, and these are known as health disparities. And in health disparities, we're always comparing the health of historically marginalized people to white Americans, which is the standard. So it's always Black versus white, or Indigenous American Indians versus white. So the health, there's always a comparison there. And so an example could be a higher incidence of lung disease among persons who smoke. This is a difference based on controllable behavior. And when disparities are caused by social determinants of health, they often result in health inequalities, meaning that there is no equality there when one group is unfairly disadvantaged compared to another. So as I said before, there was always that comparison. So an example is that Black women are 3 times more likely than white women to die from pregnancy-related causes. And research indicates people have looked into this factor and they've seen that there are things that contribute to these disparities, such as the variation in quality of healthcare that Black women receive. And there are also maybe some underlying chronic health conditions that might impact having a healthy pregnancy and birth. And of course, structural racism and implicit bias. And we'll talk about that in a little while. So really correcting health inequalities often requires rebuilding entire systems to fix the discriminatory imbalances. So in terms of healthcare access and quality, in the United States, having access to healthcare often begins with having health insurance. Without health insurance, many people do not have access to preventive medicine that can catch growing health issues early. People who live in rural or low-income areas often do not have access to health and dental providers simply because there are not enough in the area. Access to healthcare is also limited for people with limited English proficiency. Reliance on emergency rooms for basic medical care is many times an option for folks because they do not have reliable preventive health care. Now, education, access, and quality. So people with higher education levels are more likely to be healthier and live longer. So children from low-income families, children with disabilities, children who routinely experience forms of social discrimination like bullying, are more likely to struggle with math and reading. They're also less likely to graduate from high school or go to college, which means that they're less likely to get safe, high-paying jobs and more likely to have health problems like heart disease, diabetes, and depression. And of course, we do have children who also live in places with poorly performing schools, and many times families can't afford to send their children to college. The stress of living in poverty can also impact a children's brain development, making it harder for them to do well in school. And of course, access to quality early childhood education programs, which have been shown to increase school performance, is limited for children who live in poverty or in very rural areas, like on the reservations in our tribal communities. And so really, we need interventions to help children and adolescents do well in school and help families pay for college. So this will have long-term health benefits. So in terms of social and community context, people's relationships and interactions with family, friends, coworkers, and community members can have a major impact on their health and well-being. So many times there are challenges like unsafe neighborhoods, like the example I gave in the neighborhood I live in where I cannot walk. Many times there's discrimination or trouble affording the things that we need. Now, people are impacted by inflation and the rising cost of food and gas, which really impacted those in rural communities and those who use transportation as their primary form of job. So positive relations at home, at work, and in community can help reduce these negative impacts. But many times we have children whose parents are in jail, adolescents are bullied. So that really can impact the health and well-being of family. So this is where behavior interventions for parents and children can help foster communication and increase healthy interactions among folks. In terms of economic stability, in the United States, 1 in 10 people live in poverty. Many people can't afford things like healthy foods, healthcare, and housing. And people with steady employment are less likely to live in poverty and more likely to be healthy. But finding and keeping a job is very challenging in this era. People with disabilities, injuries, or other health conditions might be limited in their ability to work. And many times people who have steady work may not earn enough to afford things they need to stay healthy, especially nowadays with inflation and the rising costs of items. People live paycheck to paycheck. And so having employment programs is really important in order to bring people up to a level where they can afford things. And of course, we talked about neighborhood and built environment, having access to safe places to walk, but also living in neighborhoods where we have safe water and air and low environmental contaminants. And many times there are neighborhoods where they are exposed to toxic substances from the environment, or maybe in the workplace, secondhand smoke or loud noises, especially if you live right next to the freeway. As I said before, when I grew up, I lived in California, and most of the housing that my family could afford, we were always located near the I-5 in California, always near the freeway. So we were exposed to a lot of noise 24/7, and also to the pollution coming from the cars that were going past and by. So addressing these factors can help improve overall health. So there's a lot of things that we need to address when we're working with people in public health. So we talked a little bit about education, how education access connect to other categories of health. So let's look at a diagram. We talked a little bit about that, how educational attainment, meaning graduating from high school, can actually increase your health knowledge. And that increase in health knowledge, being able to understand information, be able to act upon it, and using problem-solving skills, can lead to you being able to choose a better diet and knowing the benefits of exercise and how other contaminants impact your ability to be healthy. It also increases your chance of getting a better job where you have better working conditions, are able to access work-related resources like health insurance, and have an income that can provide you some housing and maybe move into a neighborhood with better schools. So again, going back to my family, I am the only one that graduated from high school and then went on to college. I have 5 siblings, and all of them ended up working in the blue collar field, as they would call it, working in industry, following my parents' footsteps. And so my brother is an iron worker. My other brother works for the railroad. My sister works in an electronics factory, and one is a musician. And so in their choices of being in that working environment, they had to start working fairly early to help pay for expenses for their family. And for example, my sister works in electronics industry in Glendale, and she had to look at getting health insurance because as she was getting older, she was in that gap between before retiring that she needed health insurance, and she was having some health issues. And she found out that her company does not actually have health insurance, but has health savings accounts and health reimbursement accounts. And she was unsure what those meant. And so I had to go and discuss with her some of her options, regarding health insurance. and how to negotiate sick leave, and whether they had a wellness program in her work. So again, our education really impacts where we work and the kind of working conditions that we have. But it also really impacts, how we interact with other folks, how we cope and problem solve, and whether we have resources in order to navigate those situations, and having those social networks that help us to have health. And so really educational, making sure that our kiddos graduate from high school or get a GED, really put someone on a path to better health outcomes. So what can we do? So in order to really understand health equity, it is essential that people understand how social determinants of health really affect health outcomes for different groups. Many times when we work in public health and work in higher academic institutions, we all tend to come from the same area, same thought process, and many times we get ourselves far removed from working with people that out in the community, especially in historically under marginalized communities. And really for us, we really need to go back and start thinking about what are the issues that communities face. And so this is some of the steps you can take, and you can examine your built-in environment. You can conduct an audit in one area of the community that you work in or own your own community. So it can be like the downtown area, your trip from home to school, or just a place you visit, and look at walkability issues, transportation issues in the community. Is it safe for people to walk in the area? Are there buses or ways that people can be transported? So if we're thinking of the Abrams Center, it's located next to a major bus stop. And so are people able to get there and walk to those facilities? And are there amenities available for people? I know that one of the projects that we work on with the CDC REACH grant is encouraging people to use the loop. And one of the challenges that we're faced with is that there are no restrooms or no places to drink water on the loop. And so that's a major issue for folks. And maintenance of places. Here in Tucson, potholes are a big issue in our community. Once you have an older car and you go over those potholes, many times you have issues that impact your car. How would that really impact your ability to get to work? And of course, looking at facilities, making sure that there's places nearby where you can access libraries and health clinics and those places that are really needed. And what you do is you compare the environments of two different places. You can use the CDC's Environmental Justice Dashboard, the link I provided in the chat. And the link should take you to the Pima County Environmental Dashboard. And on that dashboard, you can look at environmental exposures, community characteristics, and health burdens of various zip codes in the area. You can actually put in your own zip code and see where your community is in terms of the index of social vulnerability, whether there's Superfund sites near you, walkability. So that's really important to be able to look at your place there. So when we look at, and in that index, actually, you can look at the social determinants of health. So they have 5 that they look at. So it'll be healthcare access and quality, education access and quality, social community contexts, economic stability, and neighborhood and built environment. So you can actually look at your community where you live or where folks that you interact with live and how they're impacted. So it's a really important tool because the communities that we work with, the historically marginalized communities, are often disproportionately affected by environmental hazards such as pollutants and climate-related activities. Other types of exposures may be historic injustices, inadequate community design, limited access to resources, and other socioeconomic factors that can lead to those poor health outcomes, such as the increased chronic disease and complications involving pregnancy and infants. So as I said before, as you've probably heard before in other presentations, your zip code really defines your health. And so if you look at that particular index, you'll see the darkened areas where there are more opportunities or less opportunities, depending on which one you look at. So again, so when you look at the data about the characteristics of the community, ask yourself questions. Does the data provided match your preconceived ideas of the place where you live? When you look at maps, do you notice any inequalities? And are there any points of interest on the map that surprised you? And you can look at the data of your community and compare it to others, but really reflecting on that. What would a person with a visual or hearing impairment need in a community? A person who uses a wheelchair, is it safe for folks in our community to use a wheelchair? I would say not, especially in Tucson here. If you've driven around and tried walking in town, it's very challenging as it's not pedestrian friendly. I walk in town for a variety of different activities, and I could say I've always been close to being run over a couple of times. About a person with a lower income, and again, we talk about bus accessibility. It's mostly concentrated within the downtown and horizontal across Tucson, but does it go north and south a little bit more? And unfortunately, with our bus system, many times it stops at 10. And on the weekends, it has limited hours. And for those who work and depend upon the bus, it can be a challenge. When I was an undergraduate student, I worked as a waitress downtown, and I would get off at 11 o'clock because I would close at times, and evenings were the best time to work because you get better tips. But unfortunately, I didn't have a vehicle. And so once I would leave, there are no buses for me to take to go back home. And I lived in central in Tucson. So many times I would walk, and then eventually I bought a bike. And so I biked away, and then I would take rides with friends who were able to give me a ride. But, for people who do not have a car, it can be challenging. How about for an older adult? Are there services available in our community for older adults, a parent with a young child, or a teenager? And again, you can share your findings by sharing it with your group about what you found. And this is always a good way to be able to learn about different communities we're located and what kind of resources they are challenged with. And what we went through is almost very similar to using a scientific method. And so in public health research, which University of Arizona College of Public Health and other institutions like Arizona State University and Northern Arizona University do public health research where they look at the health of the public. They start with asking a question, and then they do research. They do background research, just like you did. And they come up with a question that would, which is pretty much a hypothesis, which means a question that can be testable. It can be, does bus transportation increase access to healthcare? And then you would test it with an experiment, and that can be done in various ways. You might have participated in surveys, or you might have participated in focus groups. But there might be other ways that people test it while comparing a group that receives an intervention and a group that doesn't. So it'll be like an experiment group and a control group, and compare whether this intervention works. And they use it, and then they would analyze the data they collect, whether through observation, having people write down what they see, counting how much it works using questionnaires, asking people directly through interviews, or asking people who who observed and know about the situation. That would be stakeholders, and collecting all the information, analyzing that data. And that's where a lot of folks would use statistical tools. You've probably heard of using Stata, R, all those. So those are utilized to analyze data, and information that's information that comes out of this statistical software is analyzed further, and then conclusions are drawn, and this information is shared with the public, or the information is utilized to provide facts for policy change. And policy change is really where we influence rules, regulations, procedures at the local, state, and national level to really change the laws that really would impact people's health. Say, for instance, an example is tobacco, use of commercial tobacco. So researchers looked at tobacco and they found out that there was a direct link to lung cancer. And there, at the same time, advocates who were exposed to work secondhand smoke, flight attendants, an example, sued the companies, again, using research and information to prove that they were exposed to high levels of tobacco smoke while they're working, and secondhand smoke, and receiving diagnosis of lung cancer and other cancers. They're able to prove that tobacco smoke was really dangerous to health, and advocates asked to have the laws changed to where you would put labels on cigarettes to say that it was dangerous to your health, and also advocate for having changes of where commercial cigarettes are sold and who can buy them, and where you can smoke and not smoke. So that's a way that public health research has been utilized. And again, you can do similar research in the previous slides about how information can be used to help you come up with solutions. So we also, when we're talking about public health equity, we also need to look at race, equity, and health. So racism is a public health crisis. Racism structures opportunities and assigns value based on how a person looks. And really, race is a social construct based on physical characteristics. And as a result, are conditions that unfairly advantage some and unfairly disadvantage others. So racism hurts the health of our nation by preventing some people the opportunity to attain the things needed for the highest level of health. And this is directly from the American Public Health Association. We also need to be aware about implicit bias. So implicit bias are unconscious biases, are social stereotypes about certain groups of people that individuals form outside of their conscious awareness. And many times these unconscious biases develop because we grew up in our own culture, in our own environments, and we may see and observe or be told by folks, our parents, our extended networks, that this is the way we treat people. So everyone holds unconscious beliefs about various social and identity groups, and these biases stem from one's tendency to organize social worlds by categorizing. And the way that we address a bias in public health is we do campaigns and interventions. And so the newest one that came out is Hear Her. So listening to women with maternal health, especially Black women, we're able to hear concerns that could help save her life. So again, one ways that we can address implicit biases by listening and understanding where people come from. Now, institutional racism create different outcomes for different racial groups. So again, we might have implicit bias that we grew up with that really informs our assumptions and associations, and those can be reinforced through TV, through magazines, through social media, and really in many times would influence, policies and practices that were established, and those create inequitable outcomes and racial disparities. For instance, city sanitation policies that concentrate environmental hazards in communities where Black, Indigenous people of color live. Many times there are incineration plants, landfills placed in areas because the assumption is that, that people are not going to say anything, and that's not where people who of concern live. Another would be quality and funding of school systems and neighborhoods where historically underserved people live. If you compare TUSD, Tucson Unified School District, versus Catalina, a school district, and you'll see the disparities of funding through property taxes in those two areas, and how that disparity really impacts the quality of services offered, how much teachers are paid, how the facilities look like, and that really impacts a person's ability to receive a quality education. We can also look at treatment versus criminalization of drug use. We have high proportion of historically marginalized people in incarcerated facilities. And then we have, because we have high incarceration rates among Black versus white individuals, and of course, Native American Indigenous people too. And when we look at structural racism, we look at the complex system of organizations, institutions, policies, and procedures that create and perpetuate the social, economic, political arrangements that are harmful to people of color and society as a whole. So this is a little bit about what how redlining really impacts our community. So redlining is where there were certain parts of the community where people were not provided urban development, and really worked against people who lived in the area. So, of course, this would create a lower tax base, and then which, of course, would provide less funding for schools, less high graduation rates, and less access to higher education, which would lead to lower incomes. Folks who lived in the area were also unable to get a home loan, which would mean they live in a home that may have a lower value, or lived in an area that was not seen as the best place to live. So there was less transfer of wealth between generations, as the home may not have been as valuable as it would have been. And can lead to poverty and adverse childhood outcomes. So pretty much where you live, your neighborhood is really important. And historical real estate policies are really important in how it shapes where we grew up, where we live, and also where folks migrate to. So let's look a little bit at this diagram, which is the public health role to evolve. And this comes from the Bay Area Regional Health Inequities, Initiative. And so in this model, it gives you a visual that connects upstream factors such as social and institutional inequities to factors impacting living conditions to individual behaviors. So many times we overlook areas where we think public health should and should not go into. So really, we need to understand how racial inequalities really impact health. So many times we look at, in public health, we look at mortality, how people have died. We look at disease and injury, chronic disease, whether it's communicable, and the risk factors that really impact those. And so many times we look at those, and we look at doing health education in the community. We provide health care, we provide case management. But if we keep moving back a little bit, we start looking at those social determinants of health, looking at the living conditions where people are, the physical environment, the social environment, services, economic and work environments. And this is where we provide the community capacity building and the community organizing and civic engagement to help change those living conditions, and that's where policy is really important, changing those procedures and regulations to improve the living conditions of people. But when we look further, we need to look at the institutional inequities, really looking at the government agencies and the schools and what their policies are and how those can be changed in order to provide equitable access. And this is where we have strategic partnerships and advocacy with these organizations to help and really improve the health of folks. And that really goes back to the social, really addressing the social inequalities, really looking at how gender and immigration status and race and ethnicity impacts our health. So when we look at public health, we're slowly moving away from looking at, disease and looking at the social determinants of health, where we live, work, and play, and how that impacts our health. Now, we talked a little bit about this earlier, about place, race, and opportunity structures. So really, where you live really impacts your opportunity for access and likelihood of success. So we know that high poverty rates with poor employment, underperforming schools, distressed housing, and public health safety risks depress life outcomes. And so there's a systems disadvantage. And several historical housing policies have contributed, particularly to Black people, being far more likely to live in opportunity-deprived neighborhoods. So really, where a person lives and their racial background are both social constructs that significantly shape the privileges that people enjoy. So there's a linkage between place, race, privilege, and health are shaped by dominant forces that are play out in response to public policy decisions and practices of institutional actors. So let's look at the impact of historical real estate policies on location, accessibility, and investment. So real estate tells us that 3 factors determine the market value of a home: location, location, location. The same can be said about factors that determine good life and people's access to it. So place matters: location, location, location. Your neighborhood counts. Access to decent housing, safe neighborhoods, good schools, and other benefits are largely influenced by the community in which one is born, raised, and resides. And really, it's important to understand where we live. So there are several federal policies that really shaped and has worked against or together with each other. Say for we may live in neighborhoods with buildings are decaying. So those will be bulldozed for high-rise public housing. And also many times nowadays we're seeing how highways are being rebuilt in these areas. What that causes is the displacement of families and this displacing and dismantling the transportation systems of people. And we really need to look at how that would impact families. So even though we are creating new things, we're also impacting and gentrifying neighborhoods. And here in Tucson, we see that in a lot of our barrios that people are moving into, restructuring, making the arts districts, but also moving out people who live in those areas for quite a bit. So what can we do as public health professionals? So public health is what we as a society do collectively to ensure that conditions in which all people can be healthy. What we can do is we can incorporate training on racial equity and racial justice in our lives. So we have NACDD, the National Association of Chronic Disease Directors Foundations of Health Equity, is a series where there's trainings available. The American Public Health Association has a racial equity webinar series that staff, that folks that you work with can view. You can also use data to identify racial disparities and inform actions. Again, we went through that just mini example about using the environmental equity toolkit through the CDC, but we also have to use it with a health and racial equity lens. And also really looking at assessing programs and policies using a health equity framework. So the NACCD has the Moving to Institutional Equity tool, a tool to address racial equity in public health. And there's a link in your chat for this particular tool. So using a health and racial equity lens, we need to look at race and ethnicity when addressing problems, looking at intersectionalities, looking at how solutions and how to define success. Again, analyzing data and information through those lenses. Look at problems and the root causes from a structural standpoint, and name race explicitly when talking about problems and solutions, and shed light on racial dynamics that shape social, economic, and political structures. So again, when we look at the tool that I just mentioned, the Health Equity Roadmap, this one is from the American Hospital Association Institute for Diversity and Health Equity, and that they have six areas in the journey towards creating equitable and inclusive organizations. Requires us really to assess embedded practices and policies, engaging in internal and external systems changes, acknowledging structural barriers that compromise equity. Research and experience show that leading health equity strategies cut across 6 major areas within healthcare organizations. So looking at the different 6 levers of transformation to understand capabilities to improve performance, and looking at what actions you may take and how to move forward on the journey. So you're looking at culturally appropriate patient care, equitable and inclusive organizational policies, collection and use of data to drive action, diverse representation in leadership and governance, community collaboration for solutions, and systemic and shared accountability. And when you go to the website, each of those, you click on those and they'll give you more in-depth information on how that can be addressed. So we're getting close to time, so I will leave it at that. So I want to thank you for joining me for an hour to talk about public health equity and look at some of the major terms in public health equity, looking at a systems framework and how racism impacts health, and some tools that you can use personally in your work using information from the CDC, the American American Hospital Association, and their tools there. So these are things that you can use in your everyday work to help you become a better public health professional, addressing public health equity using the lens. So I am open for questions.
Thank you very much, Agnes. If we have any questions, feel free to unmute yourselves or send it via chat. All righty, it looks like there's no questions. Just one last ask that I have for you all today is if you have not filled out this tiny survey, again, like I mentioned everybody earlier today, this is a 3-question survey that I'm going to be sending out for you all. One more time in the chat. I've also updated the links that were sent out by Agnes. And if there's no further questions, thank you all for your time. Thank you, Agnes, especially for your time. And we look forward to seeing you next week. where we'll be talking about the mobile health unit and how to reach out to communities. Thank you all very much. Have a wonderful day. Thank you, everybody.